Hello, welcome again live from the 2016 AUKUS meeting. I'm here with Diane Doucette, fantastic president of the Mount Carmel, New Albany Musculoskeletal Care Institute. She's been kind enough to join us to chat a little bit about the business of orthopedics, especially from the hospital administrator side, and physician hospital collaboration, and she gave a fantastic presentation this morning on managing costs and some of the creative ways to have surgeons and hospitals work together. So let me just start out by asking you, how did you get to the place where you're the president of an entire kind of institution with an emphasis in orthopedics?
I'm a Canadian-trained registered nurse, and I came down to the Ohio area in 1990. And at that time, I met my mentor, Dr. Thomas Mallory, who was a joint replacement surgeon. And I just fell in love with joint replacement surgery. Started out and worked my way up through the ranks. And then Dr. Mallory had said, hey, I want you to go out and help my friends set up. He would have international visitors come to see our institution, and they would say, we would like to start this. So we did consulting, and then Dr. Mallory's dream and the other physician leadership in our city wanted to build an orthopedic hospital. So in 2003, we opened up New Albany Surgical Hospital, which is entirely devoted to musculoskeletal care.
Fantastic. All right. One of the topics that you had touched on was cost containment and kind of getting surgeon buy-in to the idea of cost containment. Talk a little bit about how you get surgeons on board with providing kind of an economically responsible way to take care of patients.
Surgeons are scientists, so they love data.
Okay.
And so we are very, very transparent with our data. So we'll start at a procedural level, like for example, total knee replacement, high volume procedure. And we will slice and dice that from our pharmaceutical, diagnostic testing, supplies, implants. And we slice the data that we get it down to the contribution margin level. So the surgeon will know what is he contributing to our hospital. We send this data out in the mail, blinded. And then that night, we tell them in a week we're going to have a meeting. So we're going to talk about this, and your name will be unblinded. And that's the intrigue that gets them here to the meeting. So I think that transparency of data and aligning it with outcomes. Surgeons do not want to hear all the time about costs.
Right.
They want to hear about the quality outcomes.
Right.
So we mirror their patterns, length of stay, 30-day readmissions, infection rates, and together we develop a plan for cost containment and quality improvement and patient satisfaction.
Fantastic. Now, how does the concept that you guys work with fall into the scaffold or the structure of kind of the Michael Porter, Kevin Bozick, value equals kind of outcomes over cost? Do you guys track the value of individual procedures or surgeons, or do you guys look at the kind of overall system as outcomes are readmissions and infections, or do you guys drill down even to like patient-reported outcomes as far as how patients are doing after surgery?
We meet monthly with our orthopods at all 4 sites. Mount Carmel Healthcare System has 4 sites, and each site has a monthly meeting. At those monthly meetings, we track various quality outcomes. For example, every 30-day readmission, we would drill it down to the patient. What happened, where did they go, where did they return, to try and problem solve how can we prevent this from happening again.
Okay.
Same thing if it's an infection or anything. We look at efficiencies of time, length of case times at the surgeon level. So we try to drill everything down to make it meaningful to the surgeon. We give each surgeon their patient comments quarterly.
Wow.
So the surgeons know independently who is bringing down that physician composite score in HCAHPS. Very transparent with data.
Yeah, that's fantastic. Now, how do you handle surgeon implant preference? So I know some surgeons come out of fellowship, come out of training, or work someplace, and they get very attached to a rep or an implant, and maybe it's more expensive or less expensive. Do you guys have a kind of a broader based structure that you work within?
Again, going back to our surgeons. So very pro surgeon choice, but the surgeons need to standardize the price. So what is a patella worth?
Got it.
It doesn't matter if it's vendor A, B, or C. This is what a patella is worth, and that's how we get the surgeons involved in the negotiation. Because the reps will tell you, oh, mine is cheaper.
Right.
Well, that's not always true, you know? So we, again, are very transparent with data, and we do that even with waste. Our surgeons will have a screw that'll say it's stripped, it's defective. Right. We won't pay for that. The surgeon calls it a waste, we tell the rep we're not paying for this. So again, transparency of data and tracking information on a regular basis.
So you'll get your surgeons involved even in kind of the negotiation aspects of implants.
Yes.
How much education do you have to do for surgeons? I mean, we come out of residency and fellowship with a wealth of medical knowledge, and we're really good at multiple choice test taking. But very poor business education backgrounds, most of us. How do you catch people up?
So we catch people up by teaching you on how to read a financial statement. We start at very basic, very simple, because the revenue minus the expense equals the contribution margin. So we do it at the procedural level, divided by physicians, so the physician knows what their score is. But you're scientists, you know how to read data. So as long as, which is a big issue for hospitals, we have to make sure the data is right. So we work a long time scrubbing the data, pilot it on 1 or 2 physicians to see, is this intriguing to you? And then we take it to the masses, using those 2 physicians that we pilot it with as our advocates,
right.
But we have to work together like this. If we do not work together, we are not going to be successful in healthcare.
For groups that haven't had as much success with collaboration, how can you help build the bridge if you're a surgeon or if you're an administrator and you're trying to reach the other side and find some common ground?
Well, as the independent orthopedic surgeon, you usually have a department. So you go to your department of orthopedics meeting, speak with the chairman. If you want to try an efficiency model, talk about it. You do it from the grassroots. Get the surgeon involvement, get your chief medical officer involved, and usually if you can get that inertia, get away from that and get it rolling, you can really fast track an implementation. But you need to have a physician champion that will work with the administrator. And administration will listen to you because you control 95% of the expense when you hit those keystrokes. But we've got to tell you what those keystrokes cost and how they tie back to the quality outcomes.
Yes. Now, one of the challenges I've personally had is when you're in the operating room and you want to make a decision, does your department, do your surgeons have real-time access to costs? So if I want to use implant A or I want to change it and use implant B and I say, how much more is this going to cost? Do you guys have access to that information?
Yes, we do.
Wow, fantastic.
And we share that with the physicians. And anytime there's a new product coming in, the physicians decide if that product should be coming in. So it may be on our multi-system contract, 92 hospitals of Trinity Health, but nobody has used this product, so we may not want to introduce it. So we try to work with the surgeons, but we are very transparent with costs.
Fantastic. Well, thank you very much. One of the real leaders in both cost containment, healthcare administration, surgeon collaboration. We really thank her for being a part of our conversation today, and we'll catch up with her again later.
Thank you very much for your time.
Thank you.